I think we're ready to get started. So thanks everyone for joining us today. Really happy to see so many of you interested in caregiver support and family caregivers. Just as a bit of housekeeping to get us started, please, if you have any questions along the way, please enter them in the chat. We're happy to take questions as we go, and we'll do our best to get to all of them. We're going to work to keep this discussion under 45 minutes, although it is a big topic. If we run out of time and we don't get to all of the questions that come in, we'll certainly individually answer them after the fact. So appreciate your participation in that way. My name is Shara Cohen, CEO for Carallel, and I'm really grateful to be joined by Dr. Roy Beveridge, a member of our advisory board, former CMO at Humana, a senior strategic advisor at Avalier Health. Dr. Beveridge, thanks so much for joining us. Thank you. For the next 30 minutes or so, Dr. Beveridge and I are just going to have a conversation. So before we do that, though, and get to the topic at hand, I just want to give everyone a bit of a quick foundational reminder on who family caregivers are and what they're doing. So the punchline here is that caregivers are everywhere and they're doing everything. The irony in that is that we do very little to acknowledge and support them. So 43% of adults across age demographics, across racial and cultural lines, across gender identity, are serving as family caregivers in some form or capacity. And that some form or capacity is really doing everything from groceries to meds to home dialysis to managing housing. They are providing 30 to 40 hours of free care a week. And all of that effort takes a toll. So financially, it takes a toll. 20% of caregivers report that they have a high degree of financial strain due to their caregiving responsibilities. It takes a toll. Physically, family caregivers have a higher incidence of chronic conditions and often neglect their own preventative care or their own well-being in service to their loved ones. And from a mental health perspective, there's data out that shows 85% of the sandwich generation, those who are caring both for an elderly parent while caring for children at home, have experience a higher 85% experience adverse mental health symptoms, and caregivers are more than 30% more likely to have considered taking their own life. That's about 5 times the average for non-caregivers. So in light of that vulnerability and burden, Carallel was created to support the family caregiver, to increase their resilience, and fundamentally make healthcare better by making caregiving easier. So I want to sort of set that foundation in terms of why Carallel is involved in this conversation and trying to increase the discussion around family caregivers and the role that they play in our healthcare system, and know that family caregivers are the backbone and safety net for our health system. So when they wear down, effective care wears down. The ED becomes respite care, nutrition gets sacrificed, medication gets mismanaged. The way of the caregiver is the way of all of our patients and our members. So I'm really happy to be having this conversation today to draw some connection between the caregiver and health plans, and to underscore the reliance and dependence that plans have on this hidden workforce. And so I'm gonna put Dr. Beveridge on the spot, not really on the spot, he knew we were gonna ask him some questions. But as a healthcare executive and as a physician, I'm curious if you could just share with us your view of the family caregiver, how you would describe their importance, and your perspective on how the typical health plan recognizes and approaches the family caregiver.
So I took care of patients as an oncologist for 20 years, and as a clinician, I certainly recognized and understood that the family caregiver fulfilled so many essential roles for my patient, for my patients. You know, they were the ears that they listened. They were the person who interpreted a lot of what was being said. They were the person who, at the times of the patient, my patient, when they were sick, when they were having difficulties, they were the ones who the patients leaned upon. And so without you know, any exaggeration, the caregiver was I think the word you used was the backbone for the patient to get care, but also to ensure that things got done. So when someone's not feeling well, when they're sick, when they're nauseated, when they've got confusion, it's the caregiver who actually gets the things done, which is really essential. So I think from the perspective of a clinician, it's very clear how important a caregiver is. And I would say that as an executive of a health plan, there is absolute clear-cut understanding of how important the caregiver is. The problem from the perspective of the plan is that although everyone knows how important they are, the plan doesn't know who the caregivers are. There's no data that really makes it clear, you know, is it person X or person Y? And there's no real understanding for a person of what the return, what the ROI is. Because if you don't know who the person is, you can't measure things. And by the way, a lot of the stuff we're talking about is very difficult to measure. So, you know, the financial return is clear. It's just very hard to measure.
So this is at the heart of, you know, sort of important topics to discuss. So if we're going to raise awareness of the importance and the contribution of family caregivers specifically for health plans, obviously that's our audience today, how do you think it fits? How do you think a caregiver fits into the issues that are top of mind for a plan? How do we make that connection or drive an incentive to work out some of the challenges that you just described?
Yeah, well, I would say no matter what type of plan you're in, whether it's a commercial or MA or managed Medicaid, there are some things that are really important for a plan always to focus on. So the acknowledgement that caregivers are important is great, but fundamentally each plan needs to, you know, have the data, as we just talked about, to understand who the caregivers are. They need to focus in on enrollment because they have to stay in business, and you know, we shouldn't ever disparage payers for, you know, wanting to be efficient and having enrollment. So they are focused on cost, and they should be. Because if their costs are disproportionately high compared to competitors, then their enrollment is going to be lacking, and so that's a problem. And you know, reimbursement for the work that they do is important, and you know, from a commercial standpoint, that may be in terms of the commercial rate that the employer groups are willing to pay, but in MA, you know, there's going to be a big focus on, you know, stars and CAHPS and everything else. So, you know, from a payer perspective, those are things that, you know, people are really focusing on.
Yeah, and so enrollment, cost, reimbursement. And, you know, I come from a perspective, of course, that that we need to acknowledge what caregivers represent. I said it, you said it, that this notion of the caregiver is the backbone of the healthcare system, because they're really literally propping up the system for our aging, for our complex and our vulnerable populations. And so when we see this data become more and more ubiquitous about the challenges, sort of both the heroic efforts of the caregiver and the dangers that they face in inability to cope, inability to afford, inability to tend to their own health. There's the connection between those three forces that you just mentioned, and investing in caregivers because of how reliant health plans are on them. Is that recognized? Or do you think that, you know, yes?
Yeah, it is recognized. But as I said, I think the problem remains how do you identify it, and how do you pay for it? And so, if we're going to start, you know, flipping things around, I would say, you know, to you, you know, to play the devil's advocate, if I'm the payer, tell me from your perspective, from, you know, Carallel's perspective, you know, why this is important, and, you know, how can we do this? So how can Carallel help? How can we design a system that helps these people who need help, who we acknowledge save money to the system? How do we measure, and how do we identify?
Yeah, I think that with one of my observations is that the notion of supporting family caregivers feels like a moral argument, right? That people are in need, and so we should serve that need. And I think there's a big place and importance on the moral argument, but, you know, certainly acknowledge what I think you're suggesting, which is yes, and we need to also weigh that or manage that within the operation of a business. And so I sort of go back to what is it that the family caregiver does, right? They manage bills. That includes medical and insurance management. They drive people to doctor visits. They manage medications. They make purchasing decisions. They're, as you said about your oncology practice, they're the eyes and ears watching for signs that somebody is in need of help, or that the patient or the member is in need of help. And so there's no doubt then that health plans should have a relationship, because I think that relationship connects to the three drivers that you just mentioned, right? If the caregivers, if the 43% of the U.S. adult population is in some percentage of that is helping to make decisions about healthcare coverage, supporting them becomes a competitive differentiator for attracting and retaining members. If they are managing cost for a member, so partnering with them creates an extension of a care management team. They control actions that, or heavily influence actions that directly lead to STAR's performance. So I would love to get sort of more acknowledgement that there's no better way, or there are few better ways to improve your CAHPS performance than to court the goodwill and make the life of the caregiver easier, because they are a key influential relationship. They're navigating access to care, and so it's almost like whole person care includes that family caregiver. I think to your point about knowing who they are, I think it starts with, there are a couple things that I think it starts with. And the way that we look at this, there are conditions and situations, we'll call it, where there's a high reliance on caregivers. We know that if somebody has memory loss, if somebody has had in-home care of any type, if somebody has a cancer diagnosis, that you can sort of build the list of places where there is likely caregiving, and making connections there starts to build, this sounds very impersonal, but starts to build the database of where and hotspots where the caregiving is happening. And then it becomes a question for the plan of, are you going to offer something in those moments that is of value? And that's what creates the connection. That's how you start to identify these circles of care around your members, or that your members are participating in. And it's, it may take some time to grow the count of those relationships, but it is a massive opportunity given the implied size of this population.
So, we heard from MedPAC and we heard from CMS last week that there was almost 9% growth in MA. Mm-hmm. We see that as of next year, more than 50% of Medicare will be MA. We know that this is dominated by the six large entities, and then the growth is really concentrated in those six. If we just focus in on MA as an example, we can talk about commercial also, but start with MA. How should MA players be thinking about caregivers in terms of those three things we've talked about, in terms of helping their business, growth in terms of membership, and an enhancement in reimbursement. So, and remember that a lot of the planning for 2023 is happening right now. Mm-hmm. And people quite soon will be thinking about 2024 also. So
right.
How should colleagues be thinking about this?
Well, I think, not to be too rudimentary in my answer, I think they should be thinking about it a lot, because we have a lot of conversations and relationships where organizations are looking at the caregiving community as a key relationship, as a real influencer of their performance, and others who are in a wait and see mode. It's new. It's in the list of supplemental benefits. It's a new concept. Let's sort of wait and see how it goes. I think that your points about growth in the MA market, it's not going to be a surprise to anybody on this call. It is such a hyper competitive space that at a very basic level, you have to think about what are the differentiating benefits that people will like and need. And if we know that nearly half of the adult population is on one side or the other of a caregiving relationship, then you have a really rich opportunity, in that it's a massive proportion of of your membership. So in an MA plan where people are highly likely to either be caregiving for someone or receiving care from someone, there's a need in that we know those caregivers are stressed out and we know they're overwhelmed. So in a strategy to minimize disenrollment or to attract new members, these are important people to please, and they're wanting help. And a lot of plans have introduced respite benefits and companionship as a way of providing relief in short bursts. But I think there's still a lot of goodwill and loyalty to be gained by delivering a differentiating benefit that meaningfully supports caregivers in all that they face and fundamentally makes caregiving easier. So for the product people out there, CMS created an allowable supplemental benefit for caregiver support as of January 1st last year. And there are plans that are using that mechanism to make clear their commitment to an important decision-making constituency in their membership. And so I think the calculus is pretty easy on the attract and retain membership front, which is, caregivers want help and they're grateful for it. But they're facing that now. Sorry. Yeah.
Yeah. One of the things that that I read when I looked at the Medicare data, for last week, for this last year, was that the disenrollment rates for certain plans were quite high, and I kind of, you were talking about this as a product to maybe lessen that disenrollment. How hard is that to prove? Is that something that Carallel's looking at, or how do you view this benefit in terms of reduction in disenrollment?
So yes, so I think that in people stick with what they value and what solves actual problems for them, right? And so the way that on the front end, what we view as important is delivering interactions with caregivers that solve problems, that help them navigate care for themselves or for their loved ones, that close loops on navigating social drivers. So there's a whole host of challenges that caregivers are befuddled by, and helping to close those loops creates gratitude and loyalty and ongoing interactions. And so from a disenrollment perspective, I think it's a very straightforward look at when you've supported caregivers in a meaningful way, or you've had connection with the caregiver on their caregiving needs, are they more or less likely to disenroll? And the stickiness of that relationship, it's I don't want to say it's simple, right? Because you have to be able to address their needs, but our look at it is, if people have interacted, at least in our case with Carallel and our team members, and they have supported them through and helped them navigate challenging situations, they are very unlikely to want to leave that service and that relationship. And so you can look at the enrollment year over year.
And do you think there's any selection bias? Say if you take an MA population, is this something that people should be scratching their heads about, or because you've taken care of thousands and thousands of patients, have you seen any drift towards selection bias or not?
So I think that there is we haven't seen a lot. I mean, I think this is the likelihood to engage versus are those the folks that are going to take advantage of benefits generally and therefore are sort of easier to win over. I think most of the time that we're having interactions with members or their caregivers or members who are caregivers, they are at a level of frustration. They start at a level of frustration that makes them actually, I think, more at risk of leaving, and so it becomes a remediation. Like, you know, that they're, most caregivers feel disenfranchised and left out of the conversation altogether. And so I think it's I'm sure there's a data analyst who would say this isn't the right way to say it, but I think it's selection bias in the reverse.
Mm-hmm. Okay. So I mean, MA seems pretty clear to me. I also know that you've got a lot of contracts and work with a lot of commercial plans. Should we think about things the same way, or are there differences between commercial plans where people will tend to be younger versus, you know, MA or managed Medicaid or something else like that? So how on the commercial side should we think about this?
Yeah, I think on the commercial side, it actually gets a little bit more straightforward in that, you know, for MA and managed Medicaid, you're talking about benefiting both a caregiver and a member who is reliant on a caregiver, and responsibility for both of those, you know, personas. Whereas on the commercial side, as you said, they tend to be younger, they tend to be the caregiver themselves. And so I think that actually simplifies your target audience a little bit. And I think that where the opportunity is really rich today to think about, to prioritize caregivers as part of a product strategy, is that the strain of caregiving on employees is really front and center for employers, right? And this has been, I think this was, we were certainly seeing this trend in this direction before COVID, but COVID has certainly put a huge magnifying glass on caregiver and strain and employment. And so if you think about group plans for like the 250 plus employees and the concern that they have about retaining employees, then then as again a differentiating benefit, I think that a lot of employers are thinking about how they support the life-work balance of their employees. So McKinsey recently reported the mental health strain of caregiving, and it's at crisis levels. So the idea, again, in offering as part of group plans is a really important consideration for providing some kind of differentiating benefit for your account salespeople, national account salespeople, group salespeople. Absolutely.
And so if I understood what you just said, are there two individuals that, you know, one's thinking about in terms of the potential benefit on the commercial side? So, you know, if, you know, I've got commercial insurance, if I'm sick, I would use it, or if my spouse were sick, I would use it for my spouse. Is that how you think about it?
So we think about it broadly, both for MA and for commercial. It tends to be that sort of hybrid that you just described tends to be more prevalent on the Medicare side, just because at somebody at the young end of Medicare is likely to still be caring for an elderly parent, maybe caring for a spouse. So that there's caregiving, there are caregivers within that MA population, and then there's also the person benefiting from the caregiver in that MA population. With commercial, I think it, you know, what we see is it skews more toward the member being the caregiver, but in acute events or specific diagnoses like cancer, you're going to see that those two personas come through. But in either case, I think that creating a valued relationship with family caregivers is a huge boost to the plan itself, right? And so I think there are different strategies for reaching those two personas, but we always advocate for, if 42% of the adult population is caregiving, let's make sure that we are spreading the benefit as broadly as possible to catch those people and to provide support and to build a relationship.
So if I'm on the MA side and I'm thinking about supplemental benefits,
Mm-hmm.
you know, and I'm planning for 2023. I mean, how should I be thinking about dividing up the supplemental, you know, benefit? And obviously, you're biased. I mean, I would hope so.
Yeah.
But how should plans be thinking about, you know, dividing this benefit up? And I mean, how should they be focused on growth or, you know, cost, you know, containment or, you know, so how should they be thinking about this?
So I think that there's a bit of a danger in getting too stuck, I think, in the supplemental benefit discussion. So I think that what CMS has done is provided a really good mechanism for promoting or encouraging attention to family caregivers by creating the supplemental benefit for caregiver support. But and this is you're right, I am biased, and there's a bit of a soapbox to get on here where 2023 and for, like you said, for some with 2024, you know, there are people in need now. You know, we're seeing, there are headlines all the time about the sort of the crisis in coping and burden that caregivers are facing. And so I think that when you think about the VBID process and the timeline, I think that people should be planning ahead for 23 and 24 to provide the benefit as a differentiator, right? Everybody's got OTC, everybody's got vision. You talked about the numbers that are the growth in the MA side of Medicare, and you know, we see the big guys growing quickly. You know, we see the numbers that Centene put out go in terms of their growth. You know, we saw Humana go in the other direction. And so I think that there's a lot to be gained by thinking about a portion of your supplemental benefit offering, including caregiver support, because the need is high. But I also wouldn't wait, right? The VBID process shouldn't dictate a caregiver benefit, in part because there are other things that can impact the plans sooner, right? So if we look at particularly CAHPS, those measures that are being evaluated under CAHPS are continuing to increase. They're at 4x weighting, which means that by next year, 57% of overall STARS ratings are going to be based on CAHPS. And the value caregivers place on support, just as we've discussed, is an innovative CAHPS strategy, and I would argue better than most CAHPS strategies that we see in plans nationally. You know, Centene's good news on growth also included that they needed to focus on their STARS ratings. So I think that they're outside of the VBID process. There's lots of benefit in terms of reimbursement or cost when you think about your care management programs that can benefit plans in 2022. I mean, we're talking 23 and 24. There's opportunity in the very near term to start the work that you know sort of keyed on about identifying caregivers, starting to create those connections, building the relationships in places where there are high needs or high reliance on caregivers, and driving really important performance for plans on the things that are top of mind, so cost and reimbursement. So, you know, I know I made a bit of a moral argument earlier, and I can't help but do it again here, because I think that caregivers really do need the help and support, and we shouldn't wait until 2024 to offer it.
So, I mean, I think your point on the moral stuff is was wonderful. But from a business standpoint, when I sat at Humana, CAHPS was a huge issue. And, if I would have had a process to deliver a higher CAHPS score, the benefit financially back to the plan that allowed me to grow faster, to have better quality, to do things was really important. And I guess I can't underscore enough, how important CAHPS would be to an MA plan. I think that's one of the reasons that this would be so valuable, because the engagement, as you've said, is very, very sticky and very, very deep, and can be tied not to a third-party vendor, but can be tied directly back to the MA plan. But I think that's really important, point that you've made, and I think that's one of the thoughts to underscore why this webinar is so important.
Yeah, I think that part of the reason that the weighting on CAHPS has gone in the direction it has is, and please disagree with me if you think I'm down the wrong road here, is that it's the experience metrics and the relationship metrics that health plans have, that CAHPS were built for, have been the one thing that hasn't budged over the last 10 or 15 years. And
which is why it's becoming increasingly important, because
right.
It's relatively easy to get someone to get a guaiac test for colon cancer screening. It's relatively easy to get breast cancer screening, to get hemoglobin A1C, but CAHPS is really, really hard.
It's hard, and it's more of that sort of that failure to budge the numbers, I think, implies that new strategies are required and some innovation is required, and so that's I think it is an important opportunity, and the thing that often gets said and maybe not so much remembered is that these things take time and the goalposts move, right? So now, an improvement in CAHPS, if everybody is, I think, appropriately focused on it, might not carry as much impact for you in 2023, 2024 as you hoped. And so I think that it's not the time for business as usual on the CAHPS side. So and again, biased, but interactions of value and stickiness and actually closing the loop, going the last mile for people and connecting them to the support and services that are meaningful in their day-to-day lives is a huge contributor and opportunity.
So my last question for you, given that I tend to be the practical doubting Thomas in so many things, is how do you identify if I'm an MA plan and I'm scratching my head going, okay, interesting, or a commercial plan, whatever it is, how do you identify the caregivers? We've just said, my experience at Humana was I recognized the importance, the company recognized the importance. The challenge was to know who they were. So yeah. What's the solution for that?
Yeah, well, anytime you've got a complex challenge like that, there's no silver bullet solution, but I think there are four key practices that we focus on when we think about identifying those caregivers, and it is progressive, right? You're going to build this database, this awareness, these relationships over time, but it starts in things that the health plan controls, and then it moves out into the community. So in our 4-part practice, it starts with connection and collaboration with care management. The care and case management know oftentimes who that there's caregiving happening in their interactions, and creating seamless workflow with the care management team is one one piece of how you start to really tend to that caregiver audience. The second thing is to look within those high reliance caregiver community or conditions. So, you think about memory loss and stroke and ALS and cancer, and there are a set of diagnoses and situations in which you have claims data for that that you can hotspot and start to do outreach to then invite in the caregiver conversation. The third thing is to make it known, is to really promote the fact that you're invested in a caregiver relationship, and that takes some creativity, because half of the caregiving community does not self-identify as a caregiver. They're a good husband, a good daughter, a close friend, whatever that might be, and so you've got to be nimble in your marketing. And the fourth is to create relationship and connection points where, as we say, caregivers hang out, right? Your assisted living facilities, your community-based organizations and support groups, your things that are happening outside of the plan ecosystem that that we can promote and help create connections with caregivers, and that that takes time and focus. And so I think the recognition that there isn't a silver bullet for it is important, but the importance of the constituency of that community and the value that can be delivered to them and to be gained by having a relationship with them, I think makes it worth that work. So I know we're bucking up on time. We did get a couple questions about connection to social drivers of care, which is an incredibly important topic. And we did a previous webinar about health equity and social drivers and the role of family caregivers. And so maybe we'll share that in the follow-up. But I want to thank Dr. Beveridge for putting the screws to me on some of these questions, and appreciate the discussion, appreciate everybody's joining us. And if you have questions or follow-up thoughts, happy to hear from you each individually. And thanks for coming, and have a great afternoon. Take care, everyone.
Take care. Bye-bye.